Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome to the Health Upgrade Podcast. This is Dr. Habib. I'm really excited about today's guest. I really want to give him the honor of introducing him really well. Today's episode is with Dr. Doug Bremner. Doug Bremner is a professor of psychiatry and radiology and director of the Emory Clinical Neuroscience Research Unit at Emory University School of Medicine in Atlanta, Georgia, and a staff psychiatrist at the Atlanta VA in Decatur, Georgia. He moved to Emory from Yale in November of 2000, where he spent the first 12 years of his career. So his research has used neuroimaging and neurobiology measures to study the neural correlates and neurobiology of post-traumatic stress disorder related to combat and childhood abuse, as well as the related area of depression. His more recent work expanding to look at the relationship between brain behavior and physical health, including studies of heart disease and the brain. Really interesting research that he's done. Dr. Bremner has co-authored over 400 peer-reviewed articles and book chapters, and written or edited 9 books, including Does Stress Damage the Brain? Understanding Trauma-Related Disorders from a Mind-Body Perspective, which was published in 2002, and You Can't Just Snap Out of It in 2014, and Post-Traumatic Stress Disorder from Neurobiology to Treatment, which came out in 2016. He's on the editorial board of several journals and has received several awards for his work. And we're really, really honored to have him here. Please welcome Dr. Doug Bremner.
Thank you.
An honor to have you here. And as always, JP, great to see you.
Great to be here.
We're really excited about this conversation about this particular topic that you are so deeply invested in, and that is post-traumatic stress disorder in particular, also related to depression. And so I want to give you the opportunity just to share a little bit about your history, your story kind of going through Yale, through Emory, and what really brought you into psychiatry and your interest in PTSD to begin with.
Okay, well, thanks for having me, Dr. Habib. I started out my career at Yale as a psychiatry resident, and I was the inpatient resident on one of the floors of the VA. It was the West Haven VA in Connecticut. And that's the VA that's affiliated with Yale. And in that year, they converted the floor from a long-term psychoanalytic focused inpatient floor to disease-based model, where one floor was for PTSD patients, there's another floor for depression, and a different ward for schizophrenia and substance abuse. And I happened to be on the PTSD floor. And in that year, the Yale Psychiatry Department got a grant called the National Center for PTSD. It came from the VA. And the Yale West Haven side was the neurosciences division. And they had other divisions for education and for behavioral research. And so I was the resident there. I became the chief resident that first year that it started. And then I got a BA biological psychiatry fellowship. And I just saw it as a great opportunity to do research in PTSD. And it was a very interesting time because we did a study at the time and looked at what diagnoses these people were getting. And the diagnosis of PTSD was rarely used, although it had been first established in 1980. This is about 1990, and most people were getting other diagnoses. So they weren't really being properly diagnosed and, often not getting the right treatment.
Absolutely. Go ahead, JP.
We moved to Emory. Yeah, when you moved down to Emory, obviously that interest in PTSD remained. Can you give us a little sense as to how that move took place and how the continuation of that work has sort of blossomed into a pretty remarkable career at this point?
Yeah, thanks, JP. So I was doing research in PTSD. We did the first brain imaging study in PTSD was in veterans using magnetic resonance imaging or MRI to look at volume of a brain area called the hippocampus. And at the time, there really was no neurobiology research in PTSD. There's only one small clinical trial that had been done at the West Haven VA. And so it was a novel concept that there could be changes in the brain associated with psychological trauma. Nowadays, people kind of take that for granted, but at the time it was considered more of an emotional condition, and there was some pushback to the idea that you could get changes in neurobiology, even though you looked at something like the Society for Neuroscience, there were 10,000 researchers doing research on the effects of stress on the brain in animals. But somehow people didn't seem to make the connection to link that to humans. So I was, at the time, some of the people were leaving Yale to go to the NIH, and I had been collaborating on a project to look at the effects of early life trauma on the brain using MRI with the PI who was at Emory at the time. And so I was recruited to come to Emory, and I did a second residency in nuclear medicine. And so I was able to be the director of the PET Center when I came to Emory, and I saw that as a good opportunity. And so we continued doing these studies of brain imaging and PTSD, looking at the effects of treatment, including paroxetine, which is Paxil, and Dilantin on the brain, showing increases in hippocampal volume and improvements in cognition. So I had that background in studying the effects of treatment on the brain. And then an engineer from Georgia Tech who'd been working with the Defense Advanced Research Project Agency contacted me about their new program in electrics, which is how I got involved in vagal nerve stimulation research.
Is that Omar Einan?
Yeah, it was Omar Einan. He's an engineer from Georgia Tech. And so Omar had done a lot of work with DARPA, which is Defense Advanced Research Projects Agency. And he's, an inventor. So he'd been inventing various gadgets that, were useful for the military. And DARPA developed a new program called electrics, which would be like electrical RX meaning treatment. So they called it electrics, but it's spelled ELECTRX. And they were looking at any kind of, electrical stimulation or ultrasound stimulations that could be used to study physiology or develop new treatments. And one of the things they wanted to get into was PTSD. And I think he just looked around for someone local doing research in PTSD. And this is something new for me. So it was interesting. So we originally wrote a large grant, $10 million grant to do implantable VNS. They didn't fund that. And then one of the cardiologists I work with, Amit Shah, was looking around and saw a couple companies that, had non-invasive VNS, which would be cheaper. And so DARPA gave us a smaller amount, initial project to look at traumatized non-PTSD. And then when we achieved the goals for that, they gave us another amount to look at PTSD. And, to me, it was an interesting area. It was, exciting, something, a device that could be applied to all of psychiatry, the way I looked at it. So there, within the DARPA group, they have these meetings that they call performers. So there'd be short 5-minute presentations from different groups that had gotten funding for the electrics program. And DARPA would cut funding for areas where they weren't meeting their goals or that they decided weren't interesting. But we were able to keep all of our funding. But there was quite a bit of debate about whether, these non-invasive devices stimulated the vagus, in the same degree as implantable devices. But from my perspective as a clinical psychiatrist, I thought the non-invasive device was more promising because it had the capacity to be implemented in all psychiatry, whereas the implantable devices, we'd already realized that, they've been, approved by the FDA, but they had never been approved by Medicare, so they were never widely implemented.
Correct. So this is a great field to dive into and to talk about, because we've spent a lot of time on our podcast talking in the mental health area and in the neurosciences area, talking about the effect on the immune cells of the brain, the microglial cells. And one of the prior guests that we had on is a microglial researcher who's done a lot of work looking at the effects of inflammation or activation of microglial cells in the hippocampus, which is an area that you've obviously spent a fair amount of time looking at and showing that inflammation and activation of these microglial cells disrupts the ability to form new memories, disrupts the ability to recall information properly and to apply it. And so in your experiences with the vagus nerve stimulation, have you done any research looking at, or any studies looking at, the effects of the vagus nerve stimulation on these immune cells in the hippocampus or in other areas of the brain?
So, JP, as I think you may know, we did a study where we looked at the effects of VNS on interleukin 6 or IL-6 and other inflammatory markers, including TNF alpha and interferon gamma, showing that you can stimulate, the stress. You can kind of recreate PTSD symptoms or the stress response by recording a specific traumatic memory and then playing the traumatic memory back. And that causes PTSD patients to have an increase in anxiety and symptoms. And they also had this big increase in IL-6, about a 3-fold increase, which is pretty remarkable. That they have the same increase when you do what we call neutral mental stress tasks, which would be like, giving a public speech with negative feedback, which is another area of research that we do. But so in traumatized non-PTSD patients, they don't have this IL-6 response to traumatic memories. They don't get, have a heart rate or blood pressure increase either. But in PTSD, they have this big increase in IL-6. It occurs about 60 to 90 minutes after the stressful script, and it's blocked by VNS. And VNS also blocks the interferon gamma and TNF alpha response. So we're seeing a pretty dramatic block. The other interesting thing about the hippocampus is that, in COVID, which is another potential application of VNS, I'm on this committee called Researching the Effects of COVID Long-Term to Affect Recovery. It's called the RECOVER study. It's a study with tens of thousands of people nationwide. And so I'm on the National Neuropsychiatric Pathobiology Committee, which meets every week. So I'm very involved in that. And, I've been writing a review paper about effects of COVID on the brain and mental health. And one of the findings is that COVID is activating microglia in the brain and astrocytes. It's the activation of microglia in the hippocampus correlates with whether or not people develop delirium. So post-mortem brain examinations show that the microglia activation in the hippocampus is seen more in those who had delirium during the course of their COVID inpatient stay. So that's another that's another link. So we think that VNS is probably from animal studies that VNS activates the locus coeruleus and which has inputs to the hippocampus and is affecting neuroplasticity in the hippocampus and medial prefrontal cortex and other areas, which is probably at least part of the reason the mechanism by which it's is useful for PTSD, because we also showed that I think it was about a 21% reduction in PTSD symptoms over the sham after 3 months of twice daily treatment for PTSD. And also showed, we've been applying it to opioid withdrawal as well, showing benefit there as well. And in January 11, 2022, the FDA gave us breakthrough device approval for the gammaCore, which is one of the instruments that JP was involved in, getting off the ground.
Yes, and thanks for mentioning that. The area of focus for me recently has been around the effects of vagus nerve stimulation on both the microglial cells as well as within the microglial cells, the effect on the mitochondria. And so was wondering whether or not if you or Omar have done any work looking specifically at the intracellular effects of vagus nerve stimulation, because one of the things that we've discussed on the show is that when inflammation occurs, and let me back up one step and say, for our audience, stress can occur in a variety of different ways. It can be physical stress, emotional stress, mental stress. And the nervous system responds to stress. The autonomic nervous system responds by moving into the sympathetic state, and that sympathetic state is the fight or flight response. The immune system, it parallels that. The innate immune system parallels that by responding to stress by becoming pro-inflammatory. And so the two systems, the autonomic nervous system and the innate immune system, work together hand in hand. When the sympathetic is activated in the autonomic nervous system, you get an activation of inflammation or pro-inflammatory activity among innate immune cells like microglial cells in the brain. When that happens, there's a shift in the internal biochemistry of the cells, and that causes oxidative stress to start to occur in the mitochondria. And you see, as a hallmark of inflammation, a shift of cells away from oxidative phosphorylation as the source of energy to glycolysis. And so was wondering whether or not in the process of your research or in maybe some of Omar's research, because I know Omar largely works in animals, if he's seen this change in energy metabolism in mitochondria and whether or not it's possible to potentially consider some of these disorders as mitochondrial dysfunctions. And that really at the end of the day, we have to consider not just the autonomic nervous system, the immune system, but energy metabolism and mitochondrial function in the mix.
Well, so we haven't done any research. I don't think Omar has either on mitochondria, although there is another, I don't remember his name, but I saw a lecture by another Georgia Tech professor who is doing work on mitochondria, as I remember. And I think that, it's a likely candidate. It's sort of a new area, which is, very interesting. One thing about, related to energy metabolism of mitochondria is that one of the ways that we look at, so for these studies with VNS, we were looking at brain activation using radioactive water and positron emission tomography, but you can also look at energy metabolism with something called FTG, which is fluorine-18 labeled glucose. So the main energy source in the brain is glucose. And one of the main uses of glucose in the brain is glutamate transport, in astrocytes and mitochondria, and which is probably driven by inflammation, because we showed in the pilot study that we could do mental stress tasks and there's increased brain uptake in some key areas, including the amygdala, which plays a role in fear responses, increased FTG uptake during those mental stress tasks I mentioned before, like public speaking. So, the increased glucose utilization when people are stressed is probably a lot of it is this glutamate transport. And one of the theories of why stress causes smaller hippocampal volume, which has been shown in animal studies and in humans, has been replicated many times of smaller hippocampal volume in PTSD, is excessive glutamate release in the hippocampus during stress and kind of a failure of glucose energy utilization to kind of keep the glutamate in the cell. And as I remember, it's glutamate is transported into the microglia. I mean, I could be wrong on that. But anyway, that was one of the original theories of why stress is toxic to the hippocampus. The other idea is that cortisol may have toxic effects, or that there may be decreases in neurotrophins like brain-derived neurotrophic factor.
Yeah, one of the things that we looked at is the effect of TNF-alpha, which is obviously the archetypal pro-inflammatory cytokine released by microglia when they get activated, when stress activates them, has an effect on the entire glutaminergic system. It also affects things like upregulating AMP and NMDA receptors. And so as a result, the neurons, there's this hyperexcitability or even excitotoxicity that occurs as a result of inflammation, leading to an increase not only in glutamate expression, but also in the effectiveness of the glutamate in exciting the neurons. You see a downregulation of GABA GABA A receptors on neurons as well. So you're sort of even cutting the braking cables, if you will, on the car, so that the neurons are under constant assault of excitatory neurotransmitter activity, and their saving grace, if you will, of inhibition is being reduced. Have you seen excitotoxicity as a are you suggesting that excitotoxicity is part of the reason why you see decreased hippocampal volumes? Is there literally neurotoxicity going on in those spaces as a result of stress?
Yeah, well, one of the theories is that glutamate is excitotoxic and potentially damaging to neurons at high levels. And so one of the main theories of why hippocampal volume is reduced is glutamatergic excitotoxicity. So something that goes along with that is that, when I was at Yale, one of the discoveries was of a drug called ketamine, which is a NMDA receptor antagonist. So it's acting on the glutamate system. And I noticed at the time they were studying ketamine as a model for schizophrenia, but I walked through they called it pharmacological challenge rooms. This is in the days before brain imaging. I was walking through and I noticed that these healthy subjects that were getting ketamine had symptoms that were more like what we call dissociation than psychosis. So they were saying that they're, looking at themselves from the ceiling or feeling out of their body. And a lot of ketamine has also been used as a recreational drug. So people call it Special K, and they talk about going up into the clouds and meeting other Special K users. More recently, for a reason I didn't really understand, some of my colleagues at Yale developed it as a treatment for depression. And so now it's been FDA approved as a nasal spray and also injection for depression. But this scale that I wrote called the Clinician Administered Dissociative State Scale, which really best captured the effects of ketamine, was used, over 20,000 times by Janssen, when they did their clinical trials, and translated into, 30 languages. But they were kind of looking at dissociation as a side effect of ketamine. The interesting thing about dissociation, it's a trauma-related symptom. So when we showed that, for instance, combat veterans, if they dissociated at the time of a combat event, they were more likely to have more severe PTSD down the road. So it's sort of almost a marker, if you will, of what's going on in the brain when the brain sort of, cracks under stress, if you will. And we correlated the degree to which people have these symptoms and smaller hippocampal volume. So we think that dissociation is literally the kind of the behavioral correlate of your hippocampus going on overdrive at the time of the trauma. And the link with glutamate, is shown through, the pharmacology of ketamine. And that finding of the correlation has been replicated, a couple of times.
So help me understand that that the ketamine effects in depression, which would be therapeutic, are similar to the effects that a person who's having a traumatic event might experience if they have this dissociative break that then leads to them having a worse case of PTSD. It seems like they're pulling in opposite direction. And before you answer that, just as an aside, one of the other researchers that I've worked with before is Jeff Lewine out of New Mexico. And he did a lot of work looking at non-invasive vagus nerve stimulation and various different neurotransmitter systems. And I'm going to say it was sort of an offhand comment that he made, but he has stuck with it several times, saying that in his experience, the effects of vagus nerve stimulation have some parallels to ketamine in terms of, perhaps he's talking about the positive effects and not the negative effects, I would think. But in your experiences with ketamine and your experiences with vagus nerve stimulation, do you see any parallels? And then to the question of, how do you square the fact that in depression it's a positive and the effects mirror things that would be part of the pathology of PTSD?
Well, so for one thing, I was just looking up the name of there's a psychiatrist at Ontario. I forgot his last name, but anyway, there's some, research in animals on the effects of VNS on the brain, and it does seem to sort of parallel the effects of antidepressants. It has positive effects on serotonin, norepinephrine, and acetylcholine. It enhances synaptic plasticity in the hippocampus. We know not only that the hippocampus is smaller in PTSD, also smaller in depression, but that any treatment for depression that works for depression enhances nerve growth in the hippocampus. So the hippocampus is unique in the brain in being able to grow new neurons in adulthood. And stress inhibits that. SSRIs like Prozac enhance it, or Paroxetine, Paxil, even electroconvulsive therapy, or drugs in other non-SSRI classes like norepinephrine drugs like Reboxetine, or amino inhibitors like tranylcypromine. They all promote nerve growth. And there's a theory that that enhancement of nerve growth in the hippocampus underlies the recovery from depression, and I would argue by extension PTSD. So but the thing about with ketamine is that's something I would like to so that investigation of ketamine as a treatment for depression sort of I was involved in the research and discovering the link with dissociation, and then after I left, these studies continued, and I was not part of the original studies, and I like to kind of ask some of the my colleagues at Yale why they thought that it might be a useful treatment for depression, because I always thought, well, this is sort of a marker of pathology. So it is paradoxical. I've often wondered that, but why, so that's a good question. The other question is like, why is it that VNS activates the locus coeruleus where norepinephrine is located, but then in the periphery, it blocks sympathetic function? So normally if you put a electrode in the locus coeruleus, which is the brainstem where all the norepinephrine cell bodies are in a monkey, and activate it, then you get released norepinephrine throughout the brain, and it stimulates the fight or flight response. That goes through the hypothalamus and stimulates the peripheral sympathetic response, which increases heart rate and blood pressure. But we actually see the opposite. So there's some paradoxes within the VNS field that are kind of parallel paradoxes to things like ketamine. Why is ketamine efficacious? But we know that it does work for depression. It works more rapidly than antidepressants do.
Yeah, we focused a lot on the upstream effects from the locus coeruleus. When you're coming into the nucleus tractus solitarius in the afferent direction, you're going to activate the locus coeruleus. You see an upregulation in serotonergic activity from the raphe nucleus, but you also see activation of the release of acetylcholine. And I actually think that that's sort of where the game begins. That the norepinephrine release is important, but it's not critical. It's simply the mechanism by which other systems are being activated. And it's the release of acetylcholine widely throughout the central nervous system that leads to the effects on the immune cells. So if I can sort of tie back all the different pieces that you've been talking about to be consistent with what we've sort of learned through other interviews, we have a system that becomes hyperactive and hyper-responsive in a pro-inflammatory way as a result of stress. And that stress leads to the release of release of pro-inflammatory cytokines like TNF-alpha. TNF-alpha and other pro-inflammatory cytokines has an effect on serotonin metabolism, or tryptophan metabolism, and the synthesis of serotonin. It actually suppresses it. So inflammation has the ability to reduce serotonin synthesis as well as reduce or activate the reuptake mechanism. So I like to say that inflammation is a selective serotonin reuptake enhancer. It's the opposite of an antidepressant. But it's not, getting back to the mitochondria just briefly, one of the downstream metabolites from serotonin is melatonin. And so one of the things you see in depression and other PTSD, I'm sure, and other areas of mental health associated with this disruption in both inflammation and neurotransmitter levels is sleep disorders, this disruption of normal sleep and restorative sleep, not spending as much time in restorative sleep because you have a disruption of melatonin. But you also see a disruption in the energy metabolism. And so that's the tie back to why I was talking about mitochondria. So I think, going to maybe one of the things you were talking about before, which is the size of the hippocampus and neuroplasticity, et cetera, that you see when you treat depression is actually the same effect that you see when you treat an autoimmune disease with an anti-TNF alpha drug or an anti-inflammatory biologic. You see an increase in cognitive function, a sort of cessation of the brain fog that sometimes accompanies depression and other disorders that have an inflammatory component to them. It also relieves fatigue. So maybe switching gears here a little bit, in your PTSD patients, is fatigue a common comorbid symptom?
Not so much. I mean, headache is definitely, and of course they have severe problems with sleep. I'm sort of thinking more in terms of, there's a couple areas. One area is that, I've worked in this. There's an acting drug called Accutane that, we did some brain imaging studies of that. And so I got involved in, some of the legal battles about Accutane and its relationship with depression and suicide. And, so there's a small number of people, it's not everybody, but there's a small number of people who develop this syndrome that's very similar to long COVID. So long COVID are the long-term effects of COVID that occur for more than a month. And that's what this recovery study is all about. So with long COVID, you get this the most common symptom are fatigue and brain fog. And that occurs in about half of people. And the fatigue is extreme so that people cannot stay on task. They can't, work. They can't, do mental exertion for extended period of times. And that's very similar to this sort of post-Accutane syndrome, which, the Accutane is an isomer of the active form of vitamin A, which is retinoic acid. And retinoid binding protein is the most common protein in the cerebrospinal fluid. So retinoids have all these effects on gene transcription and other things. They're in the same family of other compounds like steroids that are also associated with psychiatric side effects. So and bodybuilding hormones, et cetera. So that syndrome with brain fog and fatigue, is similar to the syndrome with long COVID of brain fog and fatigue, which is seems to be sort of a post long-term chronic inflammatory reaction. These, with the activation of the microglia and astrocytes, possible deposition of these spike proteins, in the meninges, the linings of the brain. And so that's a very prominent part of that syndrome, which, is now probably affecting millions of Americans.
Have you done any work in this Recover program looking at vagus nerve stimulation as a potential therapy? Because
there's
a lot of benefit.
Yeah, so there's a couple of studies that come out that I reviewed this paper. One is from Bashar Badran, who's at Medical University of South Carolina, who's done. So our work has mainly been, with the device that you helped develop, which stimulates the vagus and the neck, the cervical stimulation. We've done some work with another company called Everin, which stimulates the vagus in the ear. So you can also stimulate in the ear. That's called auricular stimulation. So Bashar, who we've done some collaborations with, stimulated in the ear. And by the way, I think that probably either one is probably, evidence looks like either one is good. The people working with the cervical device will tell you that there's more vagal fibers in the neck, but in any case, so Bashar did some studies of auricular stimulation for long COVID syndrome, showing with active versus sham a reduction in long COVID symptoms, with twice daily stimulation over the course of several weeks. And then there's one study that Peter Stapps was the co-author on, looking at hospitalized patients and showing a reduction in C-reactive protein, which is a marker for inflammation in patients treated daily with the cervical device, which is the gamma core. And then, in another area of neuromodulation, Mara Bixen, who, we collaborated with in terms of validating stimulation, the cervical stimulation using mathematical models, et cetera. He was a senior author of a study in acute, patients in the intensive care unit using this transcranial direct current stimulation, which is another neuromodulation that involves this sort of headset that delivers this electrical stimulation from multiple electrodes all over the head and showing a reduction in the time spent on the ventilator, which is a pretty remarkable outcome. So, VNS should be useful for acute COVID because it, as it dilates airways, it reduces inflammation in the periphery. We've shown it blocks sympathetic function as measured with peripheral vasoconstriction, heart rate, and something called pre-ejection period, which is the time from when the left ventricle contracts to when the aorta opens, and that's a measure of sympathetic tone in the heart. So we're reducing sympathetic tone in the heart, which is good for PTSD, which is sort of a hypersympathetic syndrome, as well as opioid withdrawal, which is another hypersympathetic syndrome.
Yeah, you've certainly spanned quite a collection of indications. Our experiences also go to just the average healthy person and the benefits that they experience with it as well, which tend to be pretty remarkable and worth the 2 minutes in the morning and the 2 minutes in the evening to deliver the therapy. The role of the vagus nerve in the central nervous system versus the periphery. You said you were looking at several peripheral, cardiac and vascular effects. Are there other peripheral consequences of vagus nerve stimulation that you use to sort of determine whether or not the person has successfully delivered the therapy, or otherwise whether the effect are successful? I know obviously there's a lot of work done on circulating cytokines as well, but what else do you look at?
Well, so all of our work in humans has been in the using the cervical stimulation. So the vagus travels in the carotid sheath in the neck, and there's also branches in the ear, which is in the trochlea, which is kind of the inner part of the ear that can stimulate, which in my opinion is probably why that acupuncture point works, but that's another story. So it has fibers that travels, to the brain. So they're afferent fibers going to the brain, and also efferent fibers that go to the periphery, goes to the heart, the gut, the lungs. But at the frequency that we're stimulating that, from some of the modeling that Maram has done, it looks like that we're primarily stimulating these myelinated fibers that go into the brain, and we're not hitting the unmyelinated fibers. And so it's going through the brain, and then from there, there's outputs to the periphery. And we're looking at a number of inflammatory markers, interleukin-6, TNF-alpha, and interferon gamma. We look at heart rate and blood pressure, and then peripheral vasoconstriction is a marker of sympathetic tone. So we're looking at people when they're being stressed, both with traumatic scripts and then with these public speaking tasks, and looking for this marker of peripheral sympathetic tone, which is that people constrict their blood vessels in their finger, and we can measure that with something called photoplasmasography. And then we look at behavioral effects. So we look at, one of the outcomes is anger with PTSD patients when they hear trauma recording, or in patients with opioid withdrawal. These are people that are stopping using heroin or injectable heroin or prescription pills the night before. They come in full-blown withdrawal, very sick. And then we give VNS or sham, and we show reduction in heart rate. And we also show reduction in both subjective drug craving and withdrawal. And so that study, we were sort of green-lighted to go to the next phase, which will be a larger randomized trial of VNS versus sham control for 1 week in an inpatient unit, where the main outcome will be opioid withdrawal symptoms.
Yeah, and it's really important just for those who are listening to recognize that first week of opioid withdrawal is critical, because the transition onto medications that can help you with the withdrawal process from there on really can't initiate until you're fully detoxed from the abused drug, and that takes about a week. So the biggest failure mode of rehab is during that first week, where those withdrawal symptoms are so strong and so intense. They're all being driven by the autonomic nervous system and by the central nervous system, because there's nothing actually physically wrong with the body other than the immune system and the autonomic nervous system are completely dysregulated. And so by using vagus nerve stimulation to re-regulate them, or at least get them closer, you can ameliorate as you said, the withdrawal symptoms. It becomes less offensive, less difficult to sustain yourself through that full week. So that's the thesis, as I understand it, for the reason for the study. We obviously have great hopes for that. The opioid scourge is really taking a tremendous toll on the youth in this country. What other areas do you think vagus nerve stimulation has potential that you're not personally involved in, but you are keeping your eye on? There's obviously work in degenerative disorders, Parkinson's and Alzheimer's. There's work in stroke. There's work in some work that I'm spearheading as a result of another call that we did, another podcast in autism and schizophrenia. But what areas are you keeping your eyes on?
Well, so another new area is we got funding from the VA to look at mild traumatic brain injury, which in this study it's MTBI and PTSD comorbid. So for MTBI, for the VA's definition, it's a very lenient criteria. If you were exposed to any blast where you had momentary stunning, or if you hit your head and were momentarily confused, and you get the diagnosis MTBI. So based on that loose criteria, about 40% of people coming out of Iraq have comorbid PTSD, MTBI. And so we decided to focus on that. And then in another VA-funded study, we're looking at PTSD alone without MTBI. So MTBI and PTSD overlap quite a bit. I used to do disability evaluations for the VA because I knew something about both disorders and would try and help the VA kind of parse them out. But they overlap so much that clinically it's kind of meaningless to try and think about them separately, because they have, they share in common problems with memory, and they often PTSD patients have comorbid headache and problems with concentration and irritability, etc. But one of our findings is that if you pair, we did this in PTSD, if you pair VNS with a learning task, like trying to learn reading someone a paragraph, then asking them to remember after a 15-minute delay, there's about a 30% improvement in recall. So based on that, we kind of went through the rehabilitation arm of the VA to use this as a rehab for mild TBI and the cognitive deficits that occur in addition to the, into helping their PTSD symptoms. So, that's another promising area. And it's sort of, getting into the healthy pool, it raises this other issue of could you enhance, learning and cognition in just healthy people if you pair stimulation with, when you're maybe trying to memorize a list of vocabulary words in French or something like that. And when we were working, go ahead. Sorry.
Have you followed the work that's come out of the other DARPA program, looking at exactly what you're talking about, enhancement, performance enhancement, and cognitive enhancement associated with neuromodulation devices, and the apparent success that vagus nerve stimulation has had? The military is actually beginning to deploy vagus nerve stimulation using the cervical non-invasive stimulation for exactly that. And some of the work that they've published is very consistent with what you're talking about, where in the study that McIntyre and trying to remember his name, McKinley produced, what they did was they kept patients or subjects awake, that weren't patients because they were healthy normals, kept them awake for 36 hours and then asked them to learn some rather challenging and complicated material, and then look to see whether or not they could A, learn it, B, recall it, and apply that knowledge the next day, and whether or not they could, even as far as 90 days out, still recall the information that they learned. And the results were exactly consistent with what you just talked about, which is an improvement in the cognitive function. The work that I'm doing, as I mentioned, up in British Columbia, the long-term goal that I have with this is that I believe that in adults where neurodevelopment is largely complete, and you still have neurodevelopment in quotation marks that's going on in the hippocampus, and that's where learning and memory formation is occurring, that the reason why vagus nerve stimulation is beneficial in adults would also apply in children, but it's going to be helpful in optimizing neurodevelopment. So the reason why we're looking at it in animal models of autism and schizophrenia is because those are models where neurodevelopment is being severely challenged, severely damaged. But what happens in normal animals if you overlay vagus nerve stimulation during neurodevelopment? Can you actually optimize it beyond what is quote unquote normal? Because everybody encounters inflammation. There's always some inflammatory challenge that's present. If you can minimize the effects then of inflammation, perhaps you can optimize neurodevelopment. And I think there's some anecdotal experiences and observations that I've made that suggest that vagus nerve stimulation in children can have a pretty profound effect on neurodevelopment and can actually enhance IQ, enhance learning capability, speed of learning, ability to grasp new concepts and apply them in ways that are, I can't quantify it at this point. It's just observational, but I think that there's, something that for me personally, I find very interesting, and it's right along the lines of what you're talking about, but taking it from adults back down to children.
Yeah. So, Andy McIntyre was one of the performers in DARPA. So that's why we started, adding on this extra test of looking at the effects of stimulation during a paragraph encoding. And so I'm familiar with that work. It came out of the U.S. Air Force on a variety of different kind of performance tasks. And so their application would be, for instance, if you have fatigue servicemen that are observing, drone footage for, hours on end, they improve their ability to identify, insurgents, for instance, on drone footage. But, we did have a venture capitalist actually that came to one of the DARPA meetings, because DARPA is not only interested in developing kind of cutting edge technology that can be applied to the military, but they want to, they have this other mission, which is to translate into actual practice. And as is with NIDA, their mission is to translate VNS into clinical practice for patients with opioid disorders, which, you're exactly right when you mentioned about the opioid withdrawal. And in fact, as they're going through withdrawal, their receptors are sort of resetting so that if they do relapse and take drugs again, the risk of dying from overdose is enhanced. So that's like the most dangerous part of the course. But one of the interesting things about application so we had this venture capitalist who said, well, we had the field of artificial intelligence, and in fact we have a AI that's making a transcript of this podcast as we speak called Autopilot. I'll give you guys later. But so we have the field of artificial intelligence, but there's this other field of enhancement of human function. So I think VNS is an example of that. If you look at our findings of enhancing the ability to learn new material, that could potentially be applied to human normal, non-PTSD, normal individuals. And part of the DARPA program, they they gave a grant to Arizona State to do this ethics institute. And so we had a conference about the ethics of electrical treatments. And I talked about, what are the ethics of, that maybe some people may have access to this technology that can enhance new learning and potentially IQ in children. And some people can afford it and others cannot, so that was something that was sort of raised as a possible issue. But it is interesting. I don't know that anyone outside of the military has actually studied, healthy human subjects and the ability to enhance new learning and memory, but it'd be something that'd be very interesting.
Well, I have there's a group of researchers up in New York that are working on autism, and so they're studying the effects of vagus nerve stimulation, non-invasive vagus nerve stimulation, on the ability of autistic patients to learn, because obviously learning is generally, not always, but generally affected by autism. And so the question is whether or not they can see cognitive benefits in autistic patients. As I mentioned before, there are studies looking at the cognitive benefits of vagus nerve stimulation in patients, for example, with epilepsy, and using implanted devices for treating their seizure disorder, demonstrating improvement in verbal and spatial relations and other typically cognitive tasks, and increasing vocabulary, et cetera. So there's some reason to believe, even from prior work that was done with implanted devices in patients who had other conditions, whether they be depression or epilepsy, that vagus nerve stimulation can have this effect. I am very interested in that, the ability of vagus nerve stimulation to potentially optimize neurodevelopment, and I completely agree that there is an ethical concern, which is why I would say the solution isn't not to do it. The solution is to make it available to everybody. Find a way to make, and we already know that there are ways to activate the parasympathetic through exercise, meditation, good diet, good sleep habits, positive social environment, and things like that are already correlated with positive intellectual outcomes. We know that people who have bad diets or live in stressful circumstances and grow up in them don't end up having the same cognitive abilities as people who have what, it's typically nowadays called a more privileged upbringing. But maybe we can overcome that. Maybe we can help overcome those disparities that are just inherent in society with a technology that says, hey, if you are going to be growing up in an environment that is more stressful, where you aren't necessarily going to have the same opportunities for sort of natural anti-inflammatory, pro-parasympathetic existence, we can augment that for you. And as a result, you won't end up with a neurodevelopment that is less optimal. You can have that same optimal neurodevelopment. So, if I had the opportunity, and I don't, but if I ever have the opportunity to speak on that behalf, I would say this is a great rebalancer. This is a great opportunity to really live up to that equality that we all want by giving everybody the same opportunity to have a neurodevelopment that's positive and optimized.
Yeah, I agree. I mean, that's, in my opinion, one of the major, one of the major drivers of disparities in terms of academic performance. And we've actually shown this, that there's deficits in academic performance in children with PTSD, for example, and deficits in IQ in children. That was some work I did with Philip Size. It was a school psychologist at Columbia. But one of the major drivers of socioeconomic disparities in school performance is the stress of the environment. I mean, you can even show disparities just based on zip code. So some zip codes are inherently more stressful. There's a number of things that can contribute or have disadvantages that range from, availability of food, so-called food deserts, where people don't have access to the grocery stores to sell fresh fruit, or pollution levels. There's some evidence that levels of air particles in the air in urban environments can, even get into the brain and affect the intellectual function. And, noise levels. So people living near airports or have higher evidence of kind of activation of the fight or flight response, which can in turn impair, cognitive function and intellectual performance. So it's multifactorial and, it's and complex. But yeah, I agree. We shouldn't, of course, say, well, let's stop developing this technology because of the risk of disparities, how it's implemented. But as far as we haven't really gotten that far yet. We're still kind of looking at the effects on disease, some of these disorders that I mentioned and that you've been talking about. I can mention that there are a couple of studies in Alzheimer's disease as well, and in normal persons with implantable devices showing enhancements in learning and memory.
Yeah, it would be interesting to maybe consider a study like what you were talking about that you looked at with that researcher at Columbia, looking at children who've had experienced a traumatic event and are experiencing PTSD, and that they end up performing less well on cognitive tests, whether they be IQ tests or just school in general. Whether we could do a study demonstrating that if you take these children who have been identified as having experienced this trauma and put them on a vagus nerve stimulator, whether or not over a 6-month to a 12-month period, we see that they don't experience that retardation of cognitive development or neurodevelopment, and that they actually overcome that challenge in a way that is supportive of their overall neurodevelopment. I'd hate to be the one randomizing somebody to a sham in that, or into a matched control setting, but I think it would be just incredible to show that you can reverse that damage and allow that person to go back to a more normal, optimized, or optimal neurodevelopment, and test it. I mean, would that be something that you think your former collaborator might be interested in doing?
Well, he's actually retired now, but I'm sure he would if he were still doing these studies. A lot of the studies were done in the data was collected. Not all of it, but some of it was collected in Lebanon during the Civil War. So they had a lot of cases there. But that would be a good study to do. I'm not a child psychiatrist myself, but I think that it would be, that would be a great study for someone in child psychiatry to perform. And they do have measurements of academic performance, and you can look at those changes over time. And in terms of the ethics of it, what we usually do is we'll do a 3-month randomization to sham or active, and then we give the device. We've been getting like the electrical company to give devices to people to use on open label after the randomized study. Another thing is that there's studies in animals too showing that if you enrich environment, increases hippocampal neurogenesis, and more deprived environment is associated with the opposite. And so we have evidence that just the richness of childhood, access to, in the animal models, access to toys and even a wheel that they can run on, diversity of environment enhances hippocampal neurogenesis, and by implication enhances cognitive development. And it was even shown that just running alone, so it's been shown in marathon runners that they have increases in hippocampal volume as they train. So just running alone, and not weightlifting exercise, but aerobic exercise.
Yeah, it's that deep.
Enhances hippocampal neurogenesis, and there's studies showing that aerobic exercise is just as good as Prozac for the treatment of depression.
Right. You get that deep breathing, the stretch receptors in the lungs being activated, that pro parasympathetic activation through the afferent channels. Yeah, I
the efficient breathing patterns and the use of oxygen effectively and CO2 tolerance increasing with aerobic activity. It's a great parallel there for sure.
It would be interesting to see, and I don't know if Omar is doing any research like this, but in animals, as you said, if you have animals that are given an enriched environment, they have larger cognitive capacity. Their neurodevelopment is stronger, and that if you deprive them of that, then the opposite occurs. They have sort of and I'll misuse the term atrophy. They'll have an atrophy of that neurodevelopmental capacity. Whether or not you could prevent some of that by, even though you've given them a very limited environmental trigger, whether or not you could restore some of that with vagus nerve stimulation. By activating the vagus nerve, could you provide them with that same capacity? They won't necessarily have learned, but they'll still have that same capacity. That makes sense?
Yeah, absolutely. I think that would be a great study to do.
Well, maybe offline we'll have an opportunity to talk about some things that we could follow up on. I'd love to find some of your colleagues that are still in the field doing work, especially child psychologists or psychiatrists who would be interested in looking at the effects of vagus nerve stimulation on cognitive and optimal neurodevelopment. To me, if the only thing that the therapy ever truly did was improve the neurodevelopment of children, that alone would be a legacy that I would be very happy to be a part of. That, to me, making the world a happier, healthier, smarter place is sort of the goal everybody should have. But if we could do that, that would be pretty phenomenal.
I could give you the contact information. I know one child psychiatrist, Glenn Sachs. He's in New York, who does PTSD research, and mainly with children on burn units is a lot of the work that he's done. And I can maybe think of some others that might be good to connect with on that. I haven't seen any research in children in any of the people in the VNS field. The VNS field is not, it's still limited in size.
Right. Well, some of the work that we're looking at, as I said, is also in autism and schizophrenia, and the role of maternal immune activation in disrupting normal microglial function. The microglia are so important in neurodevelopment. They're involved in neurogenesis. They're involved in synaptogenesis. They're the principal pruners of the network. They're the ones that are involved all the way through gestation and early childhood development. And then as adults, they're still doing all those same functions in the hippocampus, to help learn and help. That's why when they're disrupted, you have difficulty learning, you have difficulty remembering things, you have difficulty recalling and applying newly learned or newly exposed information. It would be really interesting, and we're doing the work right now to show that vagus nerve stimulation can prevent that neurodevelopmental damage. Question is the other side of it also there, and that can you show that neurodevelopmental optimization can occur if you also layer vagus nerve stimulation on? So whether it be child psychologists or animal work, et cetera, I'm just very interested in seeing that, because I think it's the natural, I won't say end game, but it's a natural follow on to a lot of the work that you were doing and are doing in PTSD and in traumatic brain injury, concussion. Anecdotally, we've seen and observed lots of positive responses in patients with concussions, with really very, very brief uses of the stimulation. If they started out healthy, they get back to that healthy state pretty quickly. And maybe that's a question, getting back to PTSD. Did you find that there was a correlation between the therapeutic effect and the duration of the symptoms, or the time since the trauma occurred that led to the PTSD? Because my wonder, based on things I've seen, whether or not the longer the patient has experienced the symptoms, the longer the patient has been living under those circumstances, the more difficult it is to overcome with neuromodulation. Have you seen that?
Well, so in answer to your question, we've always tried to do studies where we get early intervention, because I agree, based on the animal literature, the earlier the intervention, when there's still more brain plasticity, the more likely there is to affect recovery. In as a practical matter, the pilot study we did in 20 patients with PTSD randomized to sham versus active. It was they are all people with chronic PTSD, both veterans and with people with early trauma. So actually, that's one of the grants that I had to give back to the funding agency, was early intervention for PTSD, and the idea was to get people right when they came back from Iraq within the first year. But the problem we ran into is, this one of the symptoms of PTSD is avoidance, and so when they first get back, from being in the combat zone, the last thing they want to do is go down to the VA or whatever and spend a lot of time talking about their combat experiences. So that was something that we tried to mindfully, approach, and we're not successful. We've tried to do studies in the emergency room where we get people soon after the trauma. That also, in our hands, we have not been able to succeed, because working in the ER and people who, it's just it's a chaotic environment. The ER physicians are focused on triage and dealing with the task at hand. They don't have time to deal with talking to research assistants, et cetera. So you are right that early intervention would be ideal, but it just, as a practical matter, is very difficult. I would say that, if I were someone who, I think I, for instance, have experienced traumatic events where, for instance, a house across the street caught on fire, and I tried to rescue unsuccessfully one of the occupants. And I felt kind of a PTSD reaction come on right away. And the way knowing what I know about PTSD, I said that, avoidance is not the way to go. You sort of have to immerse yourself in it and try and work through the cognitions and the intrusive memories and the feelings associated with it. But unfortunately, a lot of people will do the opposite. They try and kind of wall it off, and then those traumatic memories become sort of what we call indelible. They get stored. They go from the hippocampus to sort of stored in long-term storage in the cerebral cortex, and then it's more difficult for them, more difficult to intervene. We know from animal studies that if you intervene, soon, if you pre-treat animals with, for instance, benzodiazepines, you can prevent the behavioral consequences of exposure to stress. So based on that, we think that earlier intervention is the way to go. But we still are getting benefit, though, from even people with these chronic diseases that they've had PTSD for 20 years or more. So it is promising in that way.
That's excellent. And you're absolutely right. Cognitive processing is really important. Being able to do that in the absence of an autonomic response is so much better, because the autonomic response that you have from the fear just disrupts your ability to cognitively process what you need to process through. And I think one of the benefits of vagus nerve stimulation is the fact that it forces that autonomic response back into the box and allows you to remain in your head cognitively capable of processing, versus being overwhelmed by hyperventilating, your blood pressure going up, your heart rate accelerating, sweating. All of those fight or flight responses get suppressed by vagus nerve stimulation. It allows you to process through what you need to process. As you said, you need to, it's funny, we talk about in the US military versus the British military, it's this cultural difference. They go out on a mission, they experience some battle, that's a firefight that's very traumatic. They come back, and in the U.S. military, they immediately bring them in, and they need to debrief. They need to go through a post-action reporting process, and that involves them reliving through remembering everything that happened and discussing it, the trauma. And yet, the British, they come back, and the very first place that they go is to the pub, and they drink. And they do their after-action reporting usually the next day. And that opportunity to go to a safe space, cushion their autonomic nervous system with a little alcohol and have some camaraderie and sort of maybe even just forget about what it is that they live through. They don't have the same degree of PTSD because they have that ability to come down off that fight or flight response more rapidly and only return to it later the next day.
Yeah, and there's even some studies, I think, in the aftermath of 9/11, there's this debriefing therapies were actually making people worse. And one of the ideas was that, it makes sense, like if you have a traumatic event, let's send in a bunch of counselors right away to talk to people to help them deal with it. But what they found is that they were doing these debriefing sessions in groups. And probably what was happening is that maybe there was an explosion in the building and I was on the other side of the building. And then you put me together with the people that were directly exposed. And it traumatizes me more because I realized, wow, I could have really been injured in this thing. And they found that, probably just leaving people alone, it was better.
This is one of the more common things that happens with firefighters and first responders across the board. It's a group that we've started to work with as well. I work with a friend of mine who runs a company called Fire to Light. And essentially they are supporting first responders, primarily firefighters who have suffered significant traumas and haven't had the opportunity to process in a very similar way. And not being given that opportunity to go to the pub and get to a safe space. A really interesting group of people that we're working with as well. So clinically, that's very relevant, I think.
For sure.
Yeah, probably the key element is in what physiological state you're in when you do reprocess it. That's probably the key element. And as you said, if you're reprocessing it in a fight or flight response, with your sympathetic system activated and your inflammatory system activated and, whatever that is doing, to neurons in the brain that are involved in memory, is probably the key. But, reprocessing it in a more, safe, subdued space is probably the key element, I think.
Yeah, that goes directly to the polyvagal theory, Stephen Ford's idea, where being in a safe space allows parasympathetic activity to turn on, vagus nerve to become activated, and allows for us not to be in this fight or flight where we're imprinting potentially on the cerebral cortex as to what actually, if there was an emotional meaning or an emotional driver in that incident that was occurring. So that goes really well to that polyvagal theory.
Sure. What are the next steps for you? We know you've been very prolific in your publishing of data and doing of studies. You mentioned the opioid study. What are the next things we should be looking coming out of your lab and your research group?
Yeah, so we had this UH3 phase of the opioid study where we're going to, that's designed to go to the FDA and get an indication for opioid withdrawal. And we're also looking at dopamine function in the brain using positron emission tomography in that study. So we're looking at the ability of BNS to hopefully enhance dopamine, release in these patients with opioid use disorder who get this sort of chronic downregulation of dopamine with extended use of opioids. And then, also, we'll be following up on the effects of BNS on cognition and ability to rehab and mild TBI patients, people with history of concussions, and look at the ability to enhance new learning and memory, as well as, the effects on the inflammatory systems in the brain. So I think that'll be keeping us busy over the next few years. We did apply for a breakthrough device indication for opioid withdrawal that the FDA approved that for PTSD, but not for opioid withdrawal. Probably because they'd already had approved this bridge device, but the bridge device, as I understand it, requires like a needle to be put in the ear. So I think that's something that people may not find as convenient. It certainly has not been widely implemented. So yeah,
I think it's a percutaneous device that requires injections or some sort of needling through the skin of the ear, and then it has to stay there for a week. So I'm not saying it doesn't work, because I think if it's the same mechanism, it probably should. But I think it might be a little easier to do something that's truly non-invasive.
Yeah, that's my opinion. And I don't own any stock in any companies or anything on purpose, just because I want to be able to talk about it without being accused of conflicts of interest. But personally, I think that we had these debates in the Dark Performer meetings where, I just said, I'm not here to study the physiology of the vagus nerve. I'm here to develop new treatments for psychiatric patients and people with related disorders like MPVI. So, I mean, the physiology of the vagus nerve is, interesting, and the effects, how it works, is of major interest to me. But, I wouldn't study it just for the sake of it alone. And that's why I think that the non-invasive devices offered more promise for psychiatry. One of the papers we wrote early on was called Back to the Future, because I was involved, not officially, but kind of informally in advising some of the people working with this company that developed the invasive device, the Cyberonics. And in fact, the advisory board of Cyberonics was pretty much everybody that I'd worked with at Yale and at Emory. So there was a little club there that, that kind of guided, that company, which did get approval from the FDA for both treatment-resistant depression and epilepsy. But, the key there was the lack of Medicare, which caused all the other insurance companies to fall suit and not reimburse for it. So here you were left with, some of my psychiatry colleagues have these clinics of people with implanted devices that we were treating for free because they couldn't even get paid for the follow-up visits. So, so that's why I think maybe this is more promising.
Well, I certainly hope so. I mean, a $30,000 implantable device, if there's something on the order of 10 million people out there who have medically refractory depression in the United States who would qualify for a surgical implant, that's $30,000. That's hundreds and hundreds of billions of dollars that would need to be spent to treat those patients. I could see why a government agency like Medicare might trip on that, and why insurance companies might be a little risk averse when it comes to that. But I think a non-invasive approach that's much cheaper and much less involved. It's on the same level of the medications that the patients are using. It would be a lot more approachable and appealing for both physicians as well as patients as well as payers to get there. I do hope that it happens. I do think it's a successful therapy, but I probably have a little bit more interest in the pure science aspects of it. But that's because I'm not a clinician; I'm a scientist. But it's wonderful to see the work that you're doing and to have had an opportunity to share with our audience the type of work that you're doing, and we wish you the best. We think that the things that you're doing are just at the bleeding edge of where we're going to be able to see this therapy go in the future. So it's great to have the opportunity to talk with you.
Yeah, it's been great to be honest in that great discussion.
Yeah, thank you so much for joining us today. It really was a wonderful discussion. I learned a lot personally, and that's really exciting for me. So to everybody who's listening, if you got to this point, great job, good work, and keep listening. And please share this with one person who you think could utilize this information to upgrade their health. And we'll catch you on the next one. Thanks, guys.
Okay, thanks.